Good evening, everybody. This is Dr. Rick Lehman in your corner with CORA, and it's August 19th, 2020. We're in the midst of, as everybody knows, a Corona COVID medical disaster here. And tonight we're going to talk about total ankle replacements, which for me is going to be very informative because everyone knows about total hips and total knees, but total ankles certainly are a little bit more rare, number one, and number two, certainly have their own set of issues, which we're going to discuss. So let's get right to it. First, I'm going to introduce or have Jodie introduce herself. You're on.
Hi, my name is Jodie Klott. I am a physical therapist at CORA Physical Therapy. I'm actually the new clinic manager in our Creve Coeur location. And I would love if anybody had any questions about therapy, please comment or reach out to me.
Great. Dr. Bagwe, please introduce yourself and thank you for joining.
Excellent. Thanks for having me. My name is Dr. Mahesh Bagwe. I'm an orthopedic surgeon in Chesterfield, St. Louis, Missouri. I have practices in South County and in Cape Girardeau. I've been in practice for 17 years now. I trained at St. Louis University Medical School and then over to University of Illinois in Chicago and then Cincinnati, Ohio for foot and ankle reconstruction. Currently, my practice is mostly lower extremity, and I'm one of the consultants for the St. Louis Cardinals for foot and ankle surgery. So with that, we have some questions we wanted to talk about and talk about total ankles, which is an interesting topic to almost all foot and ankle surgeons in the country.
Thank you very much, and thanks for joining. So I think getting right to it, first explain what is a total ankle reconstruction and explain basically the anatomy, what are we replacing, and who do you think is an applicable candidate for a TAR?
Sure. So ankle replacements, similar to total knee and total hip replacements, are more of a resurfacing of the joint. So just like hips and knees, you basically have a cutting guide that would cut the surface of the distal tibia, which is basically the end of the tibia of the long bone below your knee, and another cut on the talus, which is the other side of the ankle joint. And then you would put a metal component on either end, and then usually a piece of polyethylene or plastic between the two. So this is very similar to total hips and total knees. Now, total ankles have become more common in the last 10 to 15 years, whereas hips and knees have been very common for the last 30 to 40 years. So there's a lot more data, a lot more experience with total hips and knees. Total ankles are still developing and are increasing on the number every year as the techniques and the products and the different manufacturers improve their products.
In terms of numbers, give us an idea, let's say comparable to a total knee or total hip. What percentage do you think in terms of arthroplasties, what percentage of total hips, what percentage of total knees, and what percentage of total ankles or how much more frequently is a total hip than a total
well, it's ankle? A little bit different demographic. So the interesting thing about total ankles is ankle arthritis, severe ankle arthritis, 70% of those cases are actually post-traumatic. So usually from an ankle fracture or a major ankle trauma. Because of this, it's a younger population. So somebody who's had a motorcycle accident when they're 18 or a car accident when they're 30. So this population is usually still working age. The average age of total ankle is in the 50s versus knees and hips is more in the late 50s or 60s. So it's kind of a more active, relatively younger population. As far as the exact numbers of how many are done, it's definitely not because whereas in the hip and knee, a replacement is the gold standards for severe arthritis, and the ankle, total ankle is still very comparable in a lot of different studies to ankle fusion. So that's a whole separate topic for discussion. And ankle fusion is basically fusing the ankle solid so it doesn't move at all, but it also relieves the pain. And that technique has been around for 60, 70 years, and the technique hasn't changed dramatically. Basically, you fuse the ankle solid so it doesn't hurt anymore, but you also have some secondary problems from having an ankle that doesn't move. So it's because of that, and that's still a very tried and true and dependable procedure. Total ankles are a newer procedure that is taking over the market or the share of people who are having ankle fusions. So it's changing every year as the technique improves. More people want to keep some mobility and would elect to have an ankle replacement versus fusion.
So let me ask you a question. Your patient comes in, he had a trimalleolar ankle fracture, he's 38 years old, he's got end-stage degenerative arthritis, flattening of the talus, going in a fairly significant valgus. Do you fuse them? Do you offer them both? What do you do?
So there's a lot of factors that go into ankle replacement. And so then there's the strict contraindications. So one, I would say a very young person. So very young, I mean, that's subjective to how experienced you are as a surgeon, but anybody in their 20s or 30s, I would consider too young. And the reason is those total ankles, at best, will last 10 to 15 years. And then you're looking at a revision with higher complication rates and more bone loss, and then probably another revision with higher complication rates and bone loss at some point when they're in their 50s and 60s or even younger. So because of that, anybody who's probably under 30, I would consider an ankle fusion, especially if they're physically active. Other strict contraindications, people with Charcot neuropathy. What is that? Charcot means they have a severe neuropathy and even maybe loss of stability of their joints because of how numb their foot and ankle is. Now, that could be from a spinal injury. That could be from medications. That can be from a diabetes, which is another very typical reason. Most people have previous infections around their ankles. So like the population is one that's had 70% of them had a previous trauma. So that means they may have had previous hardware. Previous hardware means a lot of these people may have had infections. So if somebody's had a major infection on the ankle, yet they're also contraindication to put in a total ankle replacement. People who are obese or have severe medical problems that affect their soft tissue and bone healing, because with the incision in the front of the ankle, the soft tissues are very thin and healing is a major risk. Whereas around the knee and the hip, there's lots of muscle and fatty tissue to help assist with the body to heal these wounds. The front of the ankle, the tissue is very thin. And as we all know, there's just not a lot of soft tissue around most people's ankle at the site of the surgery. Because of this, when people have a wound problem, it can become disastrous with exposed metal. The ankle replacement itself is exposed to the outside world, which by definition now is infected. Other contraindications are people with poorly controlled diabetes with significant neuropathy, like I said before, people who have significant deformity. So if you have versus a hip or a knee, you create much more torque across your ankle. So therefore, the ankle has your whole body weight pivoting across it with a longer torque arm, basically. Because of this, there's a lot more stress across the ankle versus on a hip or knee, it's kind of a direct stress or rotational stress. The ankle gets a lot more torque. Because of this, there's a high risk of loosening. So we worry about people who have a very high body mass index. You're going to worry that those people are going to loosen it or pull it free. So there's some strict contraindications. And then the other one is just doctor experience. So surgeons who do fewer indications, more narrow as far as who they would do an ankle replacement with, and people who've done a tremendous amount of them or have done it for many years may be willing to expand their indications to do it on a wider variety of patients. So with those loose indications, I evaluate people if they really want an ankle replacement and I'm not comfortable with their numbness or their diabetes. There's other people who could look at it, but I want to basically be sure that the person I do a total ankle with is going to have an excellent outcome. So there's a lot of variability per surgeon is what I was trying to say as far as who's indicated for an ankle or ankle replacement versus ankle fusion. So that example you mentioned, a 37-year-old with severe ankle arthritis. To me, that person, a young man who still is working, especially if they're a laborer, would be an ankle fusion 100% of the time. Now, let's say they're 60 years old or 55. They're overall healthy and they don't have significant deformity. To me, I would offer that person an ankle replacement, especially if they want to maintain mobility of their ankle. There's a lot of advantages to keeping mobility. The biggest one is when you maintain ankle motion, you put less stress on the surrounding joints. The ankle keeps its motion, so you have less stress across the foot, across the knee. You have a better gait. Most studies show people have a more normal gait. These type of things lead to better quality of life.
That's awesome. All right, so Jodie, quick question. Let's talk about prehab and then a little longer answer. Tell us about the total ankle arthroplasty and what you tell your patients.
Yeah, so prehab is important because we want to have the best range of motion that they can have prior to the surgery, because that's only going to help their, outcomes after surgery. Making sure the mobility is good, making sure the strength not only in their ankle but their entire leg, because after a surgery like this, you have essentially to reteach yourself how to walk, and that's where our job comes in. You have to heal from the surgery, and like Dr. Bagwe said, infection and making sure we look at your incision and the healing is a big part of it. But we also, we have to make sure you're safe in mobility. We have to make sure that you're safe, if you're non-weight bearing or in a walking boot, that way you don't have other injuries while we're rehabbing, this specific injury. Like you said earlier, the difference between a fusion and a replacement is with a replacement, you are expected to get some range of motion out of your ankle again. At the beginning, it starts passive, where I would do a lot of the stretching to start with. And then it slowly progresses to active range of motion, they're stretching, and then, eventually down the line, we get to, where you're able to do calf raises again, and you're able to do, use the muscles and use your ankle joint how it's supposed to be, just with, like you said, being resurfaced.
I like to add on pre-surgical evaluations for total ankles are very important. So most of the manufacturers of total ankle replacements recommend a CT scan. You want to see where your bony deformity is, where you're missing bone. So there's usually a CT scan involved for almost every total ankle, and to plan the alignment. Now, some companies also make, such as Wright Medical, make cutting guides that make anatomic match to your bones, where you do a CT scan ahead of time, and that will give you a cutting block to do surgery more accurately. Also, you can see if there's defects in the bone that you need to fill in with some bone cement or something like that. And then with total ankles, it's interesting. One of the things we've learned from the first generation total ankles to the new total ankles are you can't leave people with deformity. So you can't do a total ankle and leave somebody's heel crooked or the front of their foot's rotated. These things either have to be corrected in the first set of surgeries, and then once they heal, you come back to the ankle, or at the time of the total ankle, you have to correct the deformity. And it's the same thing, ligament balancing. If you correct the deformity, when I say deformity, I mean, let's say somebody has an old trauma to their leg and they have some curve of their tibia above their ankle, or their heel has been kind of scarred down and stuck pointed inward for years. These things have to be corrected before you do an ankle replacement. And once again, this has to do with how much torque goes across the ankle. If it's not evenly distributed, the ankle is going to come loose and it's going to fail. So because of this, bony alignment and soft tissue balancing have to be done either as a separate surgery before a total ankle or at the same surgical setting as a total ankle, which also adds the complexity, because that means every total ankle surgeon needs to know how to do the soft tissue procedures that they might come across doing a total ankle. You find these things out ahead of time when you're examining a patient, but sometimes when you're in surgery, you find out that a major ligament such as the deltoid is unstable. Well, you need to be able to have the equipment available right then to repair it, to stabilize it, because it's going to be difficult to correct later once you have the total ankle in place. Other things about total ankle replacements, as Jodie was just talking about, similar to other joints, when things have been stiff for 20 years, 30 years, they don't all of a sudden move normally. So with a total ankle, usually we improve motion, but it doesn't usually get all the way back to the unaffected, healthy, good side. Somebody who might have, half their normal motion before an ankle replacement may get that plus a little bit more, but I wouldn't expect it to be miraculously have a motion like they had when they were 18 years old. So that is something to consider. Somebody who's had no motion at all for 20, 30 years, they may get just back a little bit of motion, but even that little bit of motion may be enough to have them walk normally and not without a limp. So it's something to consider, but it's not something that is completely correctable with the total ankle replacement.
That's awesome. So if your patient comes in and they talk about having an arthroplasty, what can they do after an arthroplasty? Can they play tennis? Can they run? Can they just walk? What are your restrictions, and what do you tell them in terms of activities subsequent to the surgery?
So for total ankles, they're very similar to total hips and knees, and that we usually don't want impact activities. So for me, total ankle activity would be things like walking, bicycling, swimming. I would not recommend jogging. I don't even think I recommend tennis. Like I said, a lot of torque going across the ankle because it's further from your center of body mass. I would not recommend playing tennis. That's probably the biggest difference to me from a knee replacement or a hip replacement. But walking, cycling, elliptical, swimming, all those things I would have no problem with. The things impact and the pounding are the things I would avoid.
Great. And you think you're going to get 10 to 15 years after an arthroplasty. So what happens? Why do they fail? Do they get loose, or what is the mechanism of failure?
Well, there's a couple mechanisms of failure. The most common is probably loose. That goes back to the forces across the ankle and the torque. So loosening, the components come loose, and then you have to consider revision. Now, Right Medical has the which is basically the main standard for revising total ankles. And this is because their system incorporates a metal stem that can go up the tibia. So when you go up the tibial shaft, you get more stability. Other manufacturers are probably developing similar products, but the more bone you take, the harder it is for the body to recover and heal. So that's why the newer total ankles versus the early ones resect much less bone and leave more of your own bone and tissue behind. But when you revise an ankle, you have to remove more bone to try to get more stability. As far as survival, it's gotten better and better. You know, some of the studies show that after 5 years, you might have a 5 to 17% revision rate. At 10 years, 18 to 30% revision rate. You go at a different way and say that, you know, you might have a 97% survival rate of the implant at 5 years. So that's another way to look at it. So overall, the numbers are improving as the components get better and patient selection gets better. But these typically aren't going to last the same way that a hip or a knee does.
That's excellent. So Jodie, how long do you think post-operatively a patient needs to come in for rehab? When do they start the rehab? And, you know, I mean, a common question is, well, how long do you think I'm going to be in rehab for? When am I going to be back to normal walking? When's my strength going to be back? So give us some parameters in terms of the length and when they would start their therapy, and when you think they'd be kind of back to a normal gait or as close to a normal gait as they could get, and when is their strength going to be back going up and down stairs, uneven ground, etc.
Yeah, well, like you said, that's everybody's first question is, when can I walk normally again? Most doctors always have their, you know, restrictions, whether they're casted right after for a little bit or they're in a walking boot. We typically don't see them until like a week and a half to 2 weeks after surgery, because you have to heal after a surgery like this. You can't just put it in and, you know, always just go walking right into therapy. So typically it's, you know, a week and a half to 2 weeks when we first see you. And then we do work on the strength of your leg. You know, people question why I have them do straight leg raises or something like that. But if we don't have your leg ready to walk, your ankle is not going to be ready to walk. And then as far as walking normally, my hope is always around like the, you know, depending on how long you're in a boot or in a, you know, a walking boot, you can walk normally, but as soon as you put a shoe on and you have more mobility in your ankle, that changes the game again. So walking normally, we hope that it's around like the 6 to 8 week, depending on, again, what your, you know, protocol says, how long you're in that walking boot, how quickly we can get you into a normal shoe. Those things also depend on the swelling after surgery like this, and swelling can last for a long time in your ankle because it's the most dependent part of you. It hangs down the lowest. So those are things. And then how long it takes, you know, anywhere 12 to 16 weeks, depending on what your activity is that you want to get back to. If it's just normal walking, you know, maybe not so much, but say, you know, if you're a kind of low impact hiker or something like that, we might keep you a little longer to make sure your balance is, you know, up to par for, you know, a little more unstable surfaces.
So I'd like to talk about the rehab. It's very similar to what you were talking about. So rehab protocols are relatively similar across the country. Some people begin early weight bearing. So ankles are a little bit different than total knees and total hips in that there are no cemented total ankles. So because of this, you're relying on the body's raw bone edges that are cut with the saw to grow into the metal. Okay, so the metal is called trabecular metal, which is kind of like a sponge surface. So the body grows into it. Now, just like a broken bone, that process takes 5 to 6 weeks. So because of that, I like to wait to do full weight bearing till 5 or 6 weeks. At 2 weeks, for the first 2 weeks, I keep people completely off of the leg just to allow the skin to heal and the inflammation and the swelling from the surgery. And at 2 weeks, I take the sutures or staples out. And that's when I start walking in a boot with a partial weight bearing. And they can start therapy at that point and just with motion of the ankle. And then at 5 or 6 weeks, if it looks great, that's when I go full weight bearing. And if it feels great with the therapist, start progressing as tolerated. So it's very similar to what you said. And so if they're putting weight on it 2, 3, 4, 5 weeks and it feels great, when they get out of the boot completely, they could be walking without a limp at 8 weeks. Realistically, that probably takes 10, 12 weeks in the people. But once they completely heal, I think every total ankle I have walks without any limp at all. Now, people may have their other hip or their other knee or something else that bothers them. But like I said, the population, the narrow population of people who, to me, are good candidates for surgery, once they've healed, they've had an excellent gait where you couldn't really tell that they had a major reconstruction in their ankle. And that's the goal for most joint replacement, is that the patient and anybody else can't tell that they had a major surgery to replace a joint.
So typically they're in the boot 4 to 6 weeks. How long, Dr. Bagwe, would you say they're going to be in the boot for? And then from the boot, you put them in a ASO, or what do you do after the boot?
Yeah, so 4 to 6 weeks in a boot. And then as their comfort goes up, I probably just go to either a simple lace-up ankle brace or a air cast ankle brace. Nothing too constrictive. They don't want to limit the motion, but they probably want a little bit of support. And then as soon as they feel comfortable, come out of that completely as well.
That's great.
On average, they're coming out of the boot, after they start full weight bearing at 6 weeks, probably within the next 2 to 3 weeks, they're out of the boot completely.
That's great. And so I'm going to ask both you guys, do you have anything to add, anything we didn't cover, anything we should cover, information that we should know about total ankles that we didn't discuss?
I would like to add, so while there are a lot of multiple manufacturers of total ankle replacements and more companies are coming out with replacements, the main 3 that are out there, Stryker has the Star total ankle, the Integra has the Salto Talaris and the Cadence, and Wright Medical has the Infinity and the Inbone. All these companies, if you're a patient looking at total ankles, it's worth going to see these websites and seeing what these ankles look like. Seeing if there's something about that one specific product that you like and that you find interesting. For instance, I do 2 different total ankles because patients started asking me about a different one that I didn't do. So I started learning how to do the Wright Medical Infinity ankle. Before that, I'd done the Stryker Star ankle. I think their results are very similar. There are definitely differences in the equipment and how they're done. And how they look when you're putting the components in, but it's worth seeing the different companies. The general concept is less bone resection, try to restore natural anatomy of how the ankle moves. These are the same type of things that for hips and knees, and then to follow this every couple of years, just like a hip and knee, to make sure that you're not wearing through that plastic. So that's another. You talked about failure before. We talked about failure before. Other than loosening of the metal components, you can have wearing through the polyethylene, which is the plastic piece. So just like in a total hip or knee, sometimes you wear through that like you would wear through a tire in your car, and you would put in a new piece of plastic, which is not the same as revising and undoing and redoing the whole surgery. You're basically putting in a new piece of plastic in there. And then the other way that you might have failure is, of course, infection, which is the one that leads to the most problems, but this is a small percentage of total ankles. So going back to the multiple manufacturers, if there's a surgeon who is very comfortable doing one product, they probably have done that one enough times that it's not worth them, completely switching to a new system if they're comfortable with one product line, but it's worth being able to see what these ankles look like, before you proceed with the surgery.
That's excellent. Thank you. Jodie, anything you'd like to add?
Yeah, my 2 cents obviously is going to be about therapy. But I just, I always tell my people not to get frustrated. This is a long process, and therapy can be painful and it can be hard. But to not get frustrated and to remember that your end goal is to be able to walk again. A lot of these people haven't had the mobility for a long time. And you just got to keep that end goal in sight of you will be able to walk again, you will be able to do this. It just is going to take some time and your body has to heal. So.
And one last question, Dr. Bagwe. Somebody comes in, they had an ankle fusion when it was in vogue, and they say, you know, I'm so sick, my back hurts, my contralateral knee hurts, you know, my forefoot hurts. Can you convert my ankle fusion and give me motion? What is the answer to that question? Is that possible?
Yes, it is possible, but it also depends on how their first surgery was done. So a lot of ankle fusions are done with removing the fibula completely. If somebody does not have a fibula, it's basically impossible to do an ankle replacement. That's one problem. If they have a previous infection or things like that, or depending on their bone loss, if they have a tremendous amount of bone loss from their previous injury and they have a stable fusion, I wouldn't try to undo that either. If their health precludes it, I wouldn't consider it. But if they have excellent soft tissues, their overall health is good, they have an ankle fusion from when they were younger, you have to remind them that these tendons and muscles don't all of a sudden start moving normal. Really what they would be gaining is 5 to 10 degrees of motion, dorsiflexion, and maybe 10 to 15 plantar flexion. They're not going to get the same amount of motion that somebody who has a ankle replacement and never had a fusion before. People who've had a fusion are not going to get a tremendous amount of motion. They're going to get a little bit of motion back. So for that to be worth it, it has to be a very clear understanding and a very specific situation.
Thank you.
Sure.
Listen, you guys were great. What we'll do is we'll edit this and we'll get everybody a copy. We should do this again, follow up probably in a few months and see if there's anything new or anything we want to add. I think you're right. I think, you know, we're seeing, obviously it's not as a common operation, but kind of like elbows, you're seeing more and more. And as the technology progresses, hopefully total ankles progress, because I mean, you see a lot more ankle fusions than I'm ever going to see, but every time I see one, it's a nightmare. I mean, back pain, contralateral knee pain.
Yeah.
It's not been a great surgery, although it does get rid of your pain.
Yeah. Yeah, it's interesting. The studies say they're comparable. My happy ankle replacement people are incredibly happy, but a well done ankle fusion also, some of them walk with no limp at all. Some of them just great, and you can't even tell. And that's usually the people who don't have much motion to start, and they've gotten used to this for 20 years. They just have pain. You get rid of their pain, and all of a sudden they feel happy as can be. Those are the happy ankle fusions. So yeah, I agree with you. Some of the ankle fusions, though, when they don't go right and they're non-unions or they're just not finished healing, they're miserable too.
I agree. Everybody, thank you very much.